Thank you for the opportunity to present and talk to you about rheumatic heart disease in pregnancy. And I think that this is a really amazing opportunity to talk to fabulous GPs and nursing staff about what the impact of pregnancy is in rheumatic heart disease. And it's a really important time in a woman's life where she does access medical care. And I think it's opportunistic that we think about pregnancy in women of childbearing age. So I wanted to start by talking about why cardiovascular disease is important in pregnancy and why we get physiological changes, and therefore why do rheumatic heart disease sufferers get worse, and why is it significant. Then I wanted to talk a little bit about how do we prepare for pregnancy and some of the strategies I would recommend, and then how do we manage a woman who's entering pregnancy with rheumatic heart disease. So we know that the prevalence of cardiovascular disease in pregnancy is increasing, and that's partly due to the fact that we have an increasing maternal age during pregnancy, and women are entering pregnancy with comorbidities such as hypertension, diabetes, some with ischemic heart disease, others with congenital heart disease. So we're getting quite a mixed bag of cardiovascular disease entering in pregnancy, and it's more and more prevalent. Of note, it is the highest cause of maternal deaths in Australia. And that's mainly from pre-existing cardiovascular disease. And really, in the developed world, we have up to 82% of women with cardiovascular disease being congenital heart disease. So that is repaired congenital heart disease entering in pregnancy. For those in the developing world, we see 89% being rheumatic heart disease. So you can see the big disparities in what we're seeing across the world, which was also highlighted by William's presentation as well. To talk briefly about the epidemiology, we have women in childbearing age who currently have rheumatic heart disease in Queensland is approximately 673 women. And this ranges from mild, moderate to severe rheumatic heart disease, along with active cases. Of those women, there are 49 that are actually pregnant, and 21 are on the register in North Queensland, So that's in North Queensland. Some recent data from the Australasian Maternity Outcomes Surveillance System said that the incidence of rheumatic heart disease in pregnancy is 4.3 per 10,000 women. And however, it's extraordinarily significant in terms of the outcomes, and I'll talk you through that in a minute. 78% of women present with, identify as Aboriginal and Torres Strait Islander in Australia, and I think that that's very significant. So let's talk about the outcomes. There was the AMOS study that was published in the BJOG in 2019. It involved 311 women. One of those women died. 1 in 10 women were admitted to CCU ICU for monitoring. And 7 babies passed away in utero. That's 3 times our national rate. And there were 2 neonatal deaths. 21% of these live-born babies were actually classified as preterm, so they were delivered more than likely iatrogenically for maternal disease that was worsening in pregnancy, and 33% were admitted into NICU. So you can see here that these statistics are way out from our national average, where the average rate of preterm delivery is 9%. Internationally, the mortality rate related to rheumatic heart disease in pregnancy is 1.9%. So that's significantly higher than in Australia. And the heart failure that occurred 50% of the time with severe mitral stenosis and 23% of the time with significant mitral regurg. A nice little case series in Cairns showed that 4 women in their 10-year case series were diagnosed with rheumatic heart disease after an acute pulmonary edema episode at the time of delivery. So these are women that probably were in the high-risk category, were not screened, and then had an acute event at the time of delivery. And that highlights really why cardiovascular disease is so important in pregnancy, because you have such significant changes in pregnancy physiology. And the female body is under so much additional stress with substantial increases in blood volume, substantial increases in cardiovascular output, heart rate, stroke volume, and then there's naturally a drop in systemic vascular resistance to compensate. But in labour, you have another additional 50% increase in cardiac output, and with every contraction, you're transfusing an extra 300 to 500 mils of blood from the placenta and the uterus back into the maternal circulation. So if you're going to see cardiovascular disease become a problem in a mother, acutely it's going to be at the time of delivery. Just another important point on this slide is that it actually takes the 24 weeks for the physiology to return to normal after pregnancy, and that is a long time. So, knowing that, how do we prepare for pregnancy? Ideally, preconceptual care is key. It allows optimisation of the management prior to pregnancy. We can risk assess women using some specific tools that I can show you now. We can make a contraceptive plan with the woman and her family, and then if they have severe disease, you can aim for interventions prior to pregnancy, which means that they'll have improved outcomes. They will have other problems that we discussed before about anticoagulation and valve prostheses and thrombosis, but in terms of the risk of maternal death is probably slightly less after an intervention. In terms of preconception care, just other things that you all do, but it's worth mentioning, is to check rubella and varicella status and vaccinate if they're not immune, cervical screening, make sure it's up to date, review medications and work out what is safe in pregnancy, what can continue, and what needs to be changed in preparation for pregnancy. If they've got a prosthetic valve, then you can look at reviewing anticoagulation, and then you also want to be looking at a pre-pregnancy echo. In terms of contraception, I don't need to tell you today what types of contraception are available, but the recommendations are for long-acting reversibles, and those would include the Implanon, the Mirena and the Kylena would be our preference. The OCP is contraindicated due to the increased risk of VTE. We would then ensure that the woman was cared for and introduced to a pregnancy heart team. And I actually think this is absolutely fundamental preconceptionally, because this is where the trust is built. This is where the rapport is built with a woman. Naturally, these women are absolutely petrified to fall pregnant or have an unplanned pregnancy. And so meeting their care providers, having a plan, knowing what's going to happen in pregnancy, knowing what the risks are proactively, makes a huge difference to the outcome. So they're the group of people that we would engage with. Cardiologists, obstetricians, anaesthetists are paramount. And then you can have maternal fetal medicine specialists, neonatologists, cardiothoracic surgeons, and a paediatric cardiologist as well. You'd also look at primary health service workers and healthcare workers, and also the new initiative of incorporating birth on country models of care principles as well. This is a more of a midwifery-led approach, but trying to provide holistic care to Indigenous and Torres Strait Islander women in their birthing areas, to incorporate some of the traditional aspects of their care. It doesn't literally mean birthing in the country with rheumatic heart disease, but it means acknowledging that this actually happened before 200 years ago, and that we need to be able to modify some of the birthing practices to adapt for cultural practices. Modifying medications, so we want to stop medications that are contraindicated in pregnancy. These include ACE inhibitors, angiotensin receptor blockers, the new ARNIs, the mineralocorticoid receptor antagonists, and the abrodine as well, which is teratogenic. You want to change your beta blocker to a more pregnancy-friendly beta blocker. So metoprolol is commonly used, labetalol is definitely used for pregnancy-related hypertension, and sotalol is also used for maternal arrhythmias. You want to continue bicillin because it's a category A in pregnancy, and it should be continued. It should never be stopped in pregnancy. In terms of assessing a woman's risk, whether this be preconceptionally or whether this is actually in early pregnancy, at the diagnosis of pregnancy, we have lots of tools we can use. The modified WHO score has been published by the European Society of Cardiovascular Medicine. It's a great guideline, but it's very, very big and chunky, but it has a fantastic table in it. But this is for all cardiovascular disease. This is not just rheumatic heart disease. The CarPreg score is looking at what is the risk of a woman having a cardiac event in pregnancy based on her symptomology and cardiovascular history leading into pregnancy. So that gives you a score system. But this has also been incorporated into our new rheumatic heart disease guidelines. So I think for busy GPs, my recommendation is to go to the rheumatic heart disease guidelines. There's a beautiful algorithm which is modified from all of the international assessment tools. And it's rheumatic heart disease specific. Okay, so I don't know whether you can see my little... Maybe not, that's okay. So there's basically 4 levels. Level 1 is the lowest risk, which really has a history of acute rheumatic fever with no carditis. They may have an atrial arrhythmia, but no demonstrated valvular disease. They are considered to be low risk in all events. The risk of their maternal cardiac events would be somewhere between 2.5 to 5%. So the management criteria would be a cardiac review with an echo, an ECG, and probably delivery in their local hospital, depending on what the outcome of those investigations are. Level 2 is definitely a bit more complex, so mild mitral stenosis, moderate aortic stenosis, moderate mitral regurg, mild left ventricular impairment. And so they've got a higher chance of having a cardiac event during pregnancy. So that would be somewhere in the order of 5 to 10% or up to 19% if they're more into a level 3. And so really they need a more urgent cardiac review and may be deemed as intermediate or high risk, and therefore possibly needing delivery in a tertiary level centre. Level 3s are definitely high-risk women who have got a chance of a cardiac event of being about 27%. These are severe symptomatic aortic stenosis, mitral stenosis with a valve area of 1.5 to 2 centimetres squared, and moderate left ventricular dysfunction. So these women are going to have more chance of having a cardiac event and will probably need to be delivered in a tertiary centre. The level 4s are the ones where pregnancy is really contraindicated. And these represent the highest risk women that enter pregnancy and have a significant chance of mortality. And we often counsel these women very early on in pregnancy or preconceptionally to say that if they did fall pregnant, it would possibly risk their life. Often women presented with, the risk assessments, they will choose not to proceed with the pregnancy on the basis that they have, other children, other family, and don't want to put their life at risk. Others will go ahead with the pregnancy, but will probably need to be in Brisbane rather than Townsville or Cairns, for example. So this is the second half of the algorithm. You can just see down the bottom about where they should be birthing, what kind of counselling they're required, how frequently they're needed to be visited, and whether they need dental checks, anaesthetic reviews. It's a fabulous algorithm, and I'll let you have a look at that in your own time. Some important red flags would be new onset progressive cough, shortness of breath, the more recent need to sleep upright, significant reduction in exercise intolerance, syncope or pre-syncope, persistently fast heart rate, and wheeze or leg edema. So, once you've diagnosed an early pregnancy, you want to have an individualised approach and a multidisciplinary team. And really, it's utilising the pregnancy heart team again, coordinating care, particularly for our regional and remote women. That's absolutely vital. So if they do require bi-monthly or monthly reviews with a cardiologist, which also requires an echo, a fetal ultrasound, a review by the obstetrician, we want to try and coordinate that within, the 24, 48-hour period that they're in the tertiary centre, and that it's streamlined and coordinated. If that's the approach that we use, we get so much more improved compliance with our women compared with if they arrive and they don't know where to go, they don't know how to get from the cardiac place to the fetal ultrasound place to the obstetrician, and it's disconnected. Obviously, we've talked about the risk assessment, we've talked about modifying cardiac medications. Unfortunately, I've got lots of beautiful slides on anticoagulation, but we probably don't have quite enough time. But also, in the guidelines, aspirin should be used in combination with anticoagulation. I know that's normally a no-no, but it reduces the chance of thromboembolic disease, plus it's risk reduction for preeclampsia. So that's very important, and I think that's a safe thing to do. Now, when we say aspirin in pregnancy, we're talking about low-dose aspirin. So 150 milligrams of soluble aspirin given at night time improves absorption in pregnant women. Fetal surveillance with tertiary level ultrasounds, and obviously echocardiography and ECGs. At the first visit, so often when you're seeing this woman for the first time, you want to ensure that you've done a detailed history, cardiovascular examination, and have a low threshold for an echo and a cardiology referral, particularly for women in the high-risk groups. You want to diagnose and date the pregnancy, and early referral to an MFM service is absolutely vital. We usually like to see the women between 12 and 14 weeks to do their nuchal translucency scan, to look at and measure their uterine artery Dopplers, to discuss treatment with aspirin, how their pregnancy course is going to go, where they're best to deliver, and really write out a pregnancy plan for you and refer appropriately to the cardiologist, anaesthetist. So all of that happens at sort of the 12-week mark. So it's a really important visit, and I highly recommend that we try and see women at that time. Obviously, we want to ensure that it's safe to proceed, and if it's not safe to proceed, that's an urgent referral, again, to a maternal fetal medicine service for counselling around whether the woman would like to proceed with interruption of the pregnancy or whether they're going to continue. Obviously, arranging a dental and anaesthetic reviews are paramount, and assessing social circumstances and requirements for travel as well. And obviously checking in with the Rheumatic Heart Disease Register is also absolutely essential. Subsequent visits, we always continue secondary prophylaxis. Again, as I said before, it's very safe in pregnancy. And you want to watch for infection because the immune system changes in pregnancy, the T cell regulation changes, therefore pregnant women are more susceptible to infections and acute rheumatic fever episodes. So that's very important that you keep an eye out for that. And you obviously, if they've got prosthetic valves, they're very high risk, so they're going to be having a lot of screening and anti-XA levels or INR levels, depending on what anticoagulation and what valve they've got. They'll often need admission into hospital for stabilisation of anticoagulation, particularly around the time of delivery, and they're often in hospital for weeks after delivery for stabilisation and rewarfarinization. I'll talk a little bit about acute presentations of rheumatic fever in pregnancy. There's minimal literature on it to guide us. We know that the Jones criteria still applies in pregnancy, so utilise the app. I think that's really important. Have a high index of suspicion in the high-risk groups. All the management that's been previously discussed is safe, except for NSAIDs, which we usually avoid in pregnancy because it does cause premature closure of the ductus arteriosus. And we also don't use ACE inhibitors or spirolactone either. We've had a recent presentation of Sydenham's chorea in pregnancy, and if that presents in pregnancy, the antiepileptics that we use, sodium valproate we don't recommend using because it's associated with congenital anomalies, but the rest are fairly good. Phenytoin we don't tend to use now just because we've got a lot of the new agents and they're fantastic. If the mother deteriorates antenatally, really we can do percutaneous therapy, and the best time is after 16 weeks. That is because organogenesis is complete and the fetal thyroid is inactive. And so that is the best time for a mum to have emergency surgery. However, if a mother deteriorates before then you have to have a very difficult conversation with the family as well as to what they want to do with the pregnancy. Cardiac surgery on bypass, it's rare, but the maternal mortality is similar to non-pregnant mortality, but the fetal mortality is much higher. However, the focus always is the life of the mother over the life of the fetus, so you will always, do the cardiac surgery for the sake of the mother, not the fetus. The indication is for failed medical therapy or intervention procedures and life is at risk. And the best time to do cardiac surgery is between 13 and 28 weeks. If you're past 26 weeks, we would seriously consider delivery. So we would give betamethasone for lung maturity, and we would look at doing a caesarean around the same time as the cardiac surgery if required. I've put this in as a little reminder that we've just talked about what's a normal pregnancy physiology and obviously what the changes in rheumatic heart disease, but if you add preeclampsia into that, it can make a heart failure situation life-threatening. And this is because preeclampsia increases the afterload. So it's a hypertensive reaction, proteinuria, leaky capillaries, acute tubular necrosis, cerebral edema. And if you've got rheumatic heart disease and you've already got cardiac lesions, this is an absolute nightmare. So you've always got to have a high index suspicion and surveillance for preeclampsia. Just a little reminder about peripartum physiology. The most hazardous time is immediately after the delivery of the baby. And like I said before, there's an autotransfusion. As the baby's delivering, the uterus lifts up off the caval vessels and there is a rush of blood back to the heart. In addition, the uterus is contracting down, expelling the placenta, and there is more blood that's coming out of the uterus back into the maternal bloodstream. And so the cardiac output spikes within the first 10 minutes of birth, and then it adapts. But it's really important. That's when you're going to have a problem with rheumatic heart disease, particularly in women that are undiagnosed. In terms of management of peripartum, ideally, if the woman has had an unremarkable pregnancy and has been asymptomatic from a cardiac perspective, timing of delivery should be at 40 weeks because you're balancing the risk of needing a caesarean unnecessarily for a failed induction, and you're also balancing the risks of stillbirth. You want to manage the third stage very aggressively. You don't want women bleeding unnecessarily with cardiovascular disease. And you also want to ensure that they are cardiac monitored for 48 hours because of the chances of cardiac or heart failure and the need for furosemide and diuretics, and monitoring the urine output is absolutely paramount in these women. Just a couple of things about labour. We often advocate for a cardiac epidural that reduces the systemic vascular resistance, drops the blood pressure, and means that there's less strain on the heart. There's also, we allow the baby to come right down onto the perineum before we allow a mum with cardiac disease to push, and we would only let her push for 30 minutes before we'd help her have a baby. And I talked about the reasons why physiologically. The advantages of vaginal birth are significant, and really caesarean section, particularly elective, would be reserved for women in that level 4 category where their life's at risk. Vaginal birth has less blood loss, lower risk of infection, lower risk of thromboembolic disease. The issues that we have, though, on a labour ward is that we don't have telemetry. And part of making this a safe environment for women with rheumatic heart disease is that you want to know what their pulse oximeter is. And some women, some anaesthetists do like an arterial line, in which then these women have to labour in CCU. And that does cause a lot of anxiety for the CCU staff. In saying that, obviously if a woman fails, it doesn't progress in labour or has a breech presentation or there's an obstetric indication for a caesarean, then of course we go ahead with a caesarean, and that doesn't change if they've got rheumatic heart disease. In terms of postpartum management, the neonatal monitoring is required after maternal beta blockers. We have breastfeeding. We absolutely encourage that, and there is a low risk of bacteremia, even though women do get mastitis, that risk is low. And we always discuss and plan contraception before discharge. And really the most important part is following up these women. Usually we see the really high risk women, the level 3s, the level 4s, every week for the first few months, just to ensure cardiovascularly that they are well, and then we return them back to their GPs. In terms of prophylaxis for infective endocarditis from a obstetric perspective, you consider for the highest risk if they're prosthetic valves, they've had previous infective endocarditis, they're cyanotic, or that they've had CDH repaired with prosthetic material. But in the most recent RDH guidelines, routine prophylaxis is not recommended, but we do utilise antibiotics for local obstetric indications, which we would normally do for any woman. So, take-home messages today: rheumatic heart disease in pregnancy poses significant maternal and neonatal morbidity and mortality. The RDH program offers unique opportunity to improve outcomes for women with rheumatic heart disease that are entering pregnancy. But really, preconceptional discussions and planning really needs to start now. And we need an individualised and coordinated approach in pregnancy is absolutely vital. Thank you very much for your time. Yes.
preeclampsia or the HELP syndrome, and then you said
Yes.
everything goes back at 24 weeks. Is there any contraindication then, because they see us for contraception, and they still go, because one lady said, I've had the HELP syndrome in pregnancy, so
Yeah.
I'm fine to go.
On the OCP.
Yeah.
Yeah. So there is a strong association with placental dysfunction, preeclampsia, and future cardiovascular disease. So a lot of the population data is showing a very strong association. I have to say, to risk reduce for women, the progesterone long-acting reversibles are fabulous, and I think that anyone that might have a cardiovascular risk, I wouldn't give them the OCP. Preeclampsia is prothrombotic. They are so intravascularly dry and hemoconcentrated. They're so at risk of clotting. So I would say no. And also that they have a higher incidence of antiphospholipid and all of those, and screening for autoimmune diseases associated with HELP and preeclampsia is really important. No, yeah, absolutely. I'd use the Mirena or the Implanon or the mini pill if they didn't want to be on a something that was invasive. Yeah.
My last question is, with the you list down the list of medications that they
Yes.
can't take, but that's for RHD.
Yes.
We don't see many RHDs, but we see more patients, reflux and stuff. Then you look up some medications and you roll penicillin category A. But some of the obstetricians said it's okay to still give the B and C, or the B more, if they're really like
Yes.
PPIs.
Yeah, absolutely.
A complete contraindication list for non-HRT that's still pregnant, or was that the main list that you can't use?
They're the main ones because, ACE inhibitors and the angioreceptor 2 antagonists, they all cause like renal tubular dysplasia in the fetus, and so they can cause renal failure, oligohydramnios, and all kinds of fetal issues. So we really don't like those. A lot of the other medications are teratogenic, so warfarin's got a embryopathy associated with it as well. So a lot of those medications are seriously not just category B, C, they're, category X. So yeah, we definitely don't like those in pregnancy. So if you've got a lady that's preconceptional, send them to an MFM service or to a cardiologist and to discuss pregnancy-related changes in the medications, because we can give you a really good plan as to what needs to be changed.
Any other questions? We could all just put our hands together.
Thank you.